Idiopathic pulmonary fibrosis, or IPF, begins deep inside the lungs at the alveoli, tiny balloon-like sacs where oxygen enters the bloodstream and carbon dioxide leaves. In a patient with IPF, thick scar tissue aggressively builds up between these air sacs and the surrounding blood vessels. The barrier becomes too dense for oxygen to cross, slowly suffocating the patient from the inside. Standard pharmacological treatments only slow this scarring process down. A lung transplant is a surgical option, but the median survival time after the procedure is just 4.5 years. The underlying issue is that IPF destroys the biological architecture of the lung. Curing the disease requires a complete physical rebuild of the entire gas exchange unit. Rebuilding that architecture is a massive biological challenge because the wall of the alveolus is constructed from two distinct types of embryonic tissue. The inner lining of the air sac originates from endoderm tissue. Endoderm is the embryonic germ layer that forms the innermost linings of the respiratory and digestive tracts. The outer structural scaffolding and the capillary network wrapped around the sac originate from mesoderm tissue. Mesoderm is the middle embryonic layer responsible for forming muscle, bone, and blood vessels. If a doctor has a freshly harvested batch of a patient's adult telomerase-positive stem cells, a rare, naturally occurring stem cell capable of forming any tissue in the body, the problem becomes geographic. How do you get those cells to accurately reconstruct both sides of this microscopic wall at the exact same time? A single-site stem cell injection into the blood or tissue cannot efficiently target both distinct layers. Regenerating a multi-layered organ requires a synchronized two-front cellular deployment. The first phase of this dual delivery protocol pools a patient's totipotent and pluripotent stem cells into a single batch. Totipotent stem cells, or TSCs, can form any cell in the human body, while pluripotent stem cells, or PSCs, can form any somatic tissue cell. These cells are suspended in a sterile saline solution and inhaled as a fine vapor through a nebulizer. Because TSCs and PSCs retain the capacity to form endodermal tissues, they migrate directly to the interior surface of the damaged alveolar sacs. Once there, they begin repairing the damage, regenerating the epithelial linings of the bronchioles, and forming fresh type 1 and type 2 pneumocytes, the specialized cells that line the inside of the gas sacs. Delivering these cells directly through the airway ensures the lung's critical inner barrier is reconstructed exactly where inhaled oxygen meets the tissue. Simultaneously, a separate batch of mesodermal stem cells is administered via a standard intravenous infusion into the patient's arm. Mesodermal stem cells, or meso-SCs, are adult stem cells specifically programmed to form structures like bone, cartilage, and blood vessels. The meso-SCs travel through the venous system into the right side of the heart, where they are pumped directly into the pulmonary artery leading to the lungs. Because meso-SCs specialize exclusively in forming mesodermal tissues, they bypass the inner air sac completely and target the exterior surface of the alveoli. They actively regenerate the destroyed pulmonary capillaries and rebuild the structural cartilage and connective tissue stroma of the bronchioles. The intravenous route directly targets the lung's exterior scaffolding, engineering the necessary blood supply and physical support to sustain the newly forming inner lining. These two distinct cellular forces arrive at the exact site of the fibrotic scarring at the same moment. The nebulized stem cells rebuild the air sac from the inside out, while the IV-infused meso-SCs wrap the exterior in a fresh, dense network of capillaries. By attacking the geographic challenge from both sides of the tissue barrier, this dual delivery method actively engineers a fully functional gas exchange unit. This dual delivery approach was tested in a Phase 1 clinical trial, specifically targeting patients with GOLD4 IPF, the terminal, most severe stage of the disease. The primary metric for success in this trial was FEV1. FEV1 stands for forced expiratory volume in 1 second, which measures the total amount of air a person can forcefully exhale to determine their functional lung capacity. This chart displays clinical results for lung capacity. Patient 1, an 80-year-old female, entered the trial with a terminal baseline FEV1 of 14%. Within a month of treatment, her FEV1 jumped to 27%. It stabilized at 25% for 8 years. Sustaining an 80-year-old terminal patient for merely a decade demonstrates that this dual delivery protocol actively halts the progression of the pulmonary fibrosis. The chart also tracks patient 2, a 61-year-old male who entered the study with a severe starting FEV1 of 25%. He underwent a more extensive regimen, receiving 1 autologous and 3 combined autologous allogeneic dual delivery treatments over the course of 7 years. Following this treatment protocol, his functional lung capacity rose to 70%. He has maintained this dramatically improved capacity, remaining completely stable for over 9 years. By respecting the distinct anatomical origins of the lung and delivering specific stem cells through targeted routes, adult telomerase-positive stem cell therapy actively engineers new tissue. It restores breath and life to patients who were previously out of options.